This is the University of Liverpool podcast. I'm Neil Morrison. It might seem a bit far-fetched now, but someday soon, we might all carry in our wallets a little card, something like a credit card. Except this card carries our entire genetic code. It's something you would hand over to your doctor when you visit, or that doctors would look for if you ended up in hospital. Another possibility is that your doctor might have your genetic profile on file, right there beside your address, your age, and your weight. Sound unlikely? Well, according to Munir Pir Mohammed, medicine of the future is set to get a lot more personal. And he says that's a good thing. That's coming up after this.
You're listening to the University of Liverpool podcast, brought to you by the University of Liverpool online programs. Make a plan to advance your career today. Study a postgraduate degree with a world-class university without leaving your home or full-time job. You don't have to go far to go further.
One of the things that makes medicine very tricky is the fact that we're all different. The same treatment given to two people with exactly the same disease may have very, very different outcomes. Take the case of the drug abacavir.
Abacavir is a drug that is used in HIV in combination with other drugs, but unfortunately in about 5 to 7% of individuals, it causes something called a hypersensitivity reaction.
Professor Sir Munir Pir Mohammed is the NHS Chair of Pharmacogenetics at the University of Liverpool.
Which is an adverse effect characterized by skin rash, shortness of breath, diarrhea, and sometimes blood pressure drops and patient collapses to the floor. It's where your body's immune system mounting an immune response which leads to a widespread systemic immune reaction, which is severe enough to cause death in some patients.
3 teams of researchers around the world, one in Australia, one in North America, and another led by the University of Liverpool, worked to find a genetic marker for this extreme reaction to abacavir. They found one gene
called HLA-B5701.
This discovery quickly led to a test for this gene.
By 2006, every patient in the UK was having that genetic test before they went on to abacavir. And that is standard practice now in the UK, in most parts of Europe, in the United States, in Australia, etc. And the net effect of that has been dramatic. Before testing, the incidence of abacavir hypersensitivity was 5 to 7%, as I said, depending which population looked at. Since testing has been introduced, abacavir hypersensitivity has virtually disappeared. I haven't seen a case of abacavir hypersensitivity for the last 5 years or so.
So hypersensitivity reactions used to happen in 5 to 7% of cases, but in the past 10 years, it has virtually disappeared. This is a remarkable success, but consider for a moment the potential cost. Remember, the test is not necessary for at least 93% of people with HIV. But for it to be successful, 100% of patients need to be tested. That's a lot of negative tests. It seems like an expensive way to go about prescribing medicine, but it turns out it's actually cheaper than not testing. Pir Mohammed's team did a cost-benefit analysis of the test and found that administering it to every patient was less expensive than dealing with the consequences of people reacting to the drug. And here's why.
The genetic test is easy to do, although it is an added cost when you're doing additional tests such as a genetic test. But because the reactions can be quite severe, they cost a lot of money to the NHS. So for our analysis, we were able to identify patients who had these hypersensitivity reactions. So we were able to show that the cost varies according to the severity of the reaction. So one patient who lived round the corner from a hospital was able to go to the hospital pretty quickly, get his drug stopped, and didn't really need admission to hospital and cost the hospital very little money. Another patient was admitted and was in hospital for 2 weeks and cost the hospital about £20,000. So the cost varies.
But Pierre Mohammed's team showed that when you compare the average cost of the hypersensitivity reactions to the cost of doing the test on everyone, and in that way avoiding the reactions, you end up saving money. So it's not only effective, it is cost-effective too. But in some ways, this seems like a more advanced version of what doctors have always done. For example, when your doctor prescribes antibiotics, she will ask if you are allergic to penicillin. When assessing your risk for cancer, she will ask about your family history with the disease. So the question is, how is personalized medicine different from how medicine has been practiced for years?
So doctors for centuries have been trying to personalize, and they personalize based on the information you get from the patient. They personalize on the basis of what's in the literature. But those kind of clinical parameters we use and the clinical history we use is pretty crude. But it's the best thing that we've had. And so that clinical history still remains very important. That doctor-patient conversation still remains. However, we refine that by adding in these sophisticated genetic tests or other types of tests on top of that, and that increases your ability to be able to predict whether a patient is going to react adversely or well to a particular drug.
So one way personalized medicine is allowing for individually tailored therapies is that it allows doctors to avoid adverse reactions to particular drugs. But genetic testing is also helping to personalize medicine through the development of targeted therapies.
The two examples of that, one is to actually identify a drug which will help you respond to a particular disease process. And the best example of that is in cancer. Cancer is basically a genetic disease. People are identifying mutations within cancer, and people have then developed, drug companies have developed drugs which particularly attack those mutations in cancer. And in that situation, it's called targeted therapy. Or precision medicine in cancer. And you can first of all identify a patient who's got a cancer. You can then undertake the mutation screening in the cancer. And if the patient's positive for that mutation, you can give them that targeted drug. But those patients who are negative for that mutation, you don't give them that drug, you give them a separate drug. And when you have that mutation for particular cancers, you can get a dramatic effect. An example of that, I'll give you two examples. The one example is in melanoma, malignant melanoma. About 50% of patients have a mutation in a gene called BRAF. And that mutation increases your response to a drug called vemurafenib. Sometimes the tumor just melts away within a couple of weeks.
But cancer is, of course, notoriously complex and difficult to treat. In this case, 6 months after the tumor melts away, you tend to get a buildup of other mutations, and the cancer reemerges. So other targeted therapies are needed for each of these mutations.
Another example is in lung cancer, where they've identified a mutation in a gene called ALK, in 3% of patients with different forms of lung cancer. And there's drugs out there which are available which actually attack that particular mutation in 3% of individuals. And again, the tumor responds much better than when you don't have that mutation.
So targeted therapy is a great example of personalized medicine because it involves the creation of a specific drug aimed at specific genetic markers that only a small subset of the population might have. And it's not just for cancer.
For example, cystic fibrosis. We know that the mutation occurs on chromosome 7, and there are many different mutations. And there's one particular type of mutation which occurs in 4% of individuals with cystic fibrosis. Drug companies have been able to work out how they might be able to develop drugs which target that 4% of mutations. And this drug is now being used in the cystic fibrosis subsets of patients and has having a marked effect in improving their lung function overall.
Now, we've looked at how personalized medicine can be used to avoid adverse reactions to drugs. We've looked at targeted therapies that identify your genetic makeup and target a therapy specific to that. But can it also be used to help with dosing, with figuring out exactly how much of a certain drug a person needs?
Yes, very much so. That is very important, and this is something that we are really working on in Liverpool. Um, Paracelsus, who was a polymath in the 15th and 16th century, basically said that the dose of a drug is either a remedy or a poison. And we haven't really learned from that, unfortunately, 500 years later. And so what we really need to do is to bring medicine and the way we dose patients into the 21st century. And we really need to go to the era of precision dosing. Because if I gave 100 people in a room the same drug at the same dose, there will be marked variation in how much of that drug actually gets into the bloodstream. And so those people who have very high levels in the bloodstream will be more likely to get adverse effects from the drug. Those people who have very low levels in the bloodstream are likely to get no benefit from the drug. So what we want to do is to make sure we get precise dosing, precision dosing, so that people get the right amount of drug in their bloodstream to have the maximal benefit and minimal adverse effects. And so we've been doing that with warfarin, which is an important anticoagulant, which is used by about 1.5% of the population in both the UK and the United States, so huge numbers of patients.
Let's just take a moment to explain why it is so important to get the dose right for something like warfarin. Keep in mind, warfarin is a common ingredient in rat poison. It's a blood thinner that's used to reduce the risk of things like strokes. If the patient gets too little of it, then it has almost no therapeutic effect. But if the patient gets too much, it can cause internal bleeding. So it's a careful balancing act.
Yeah. But if you look at warfarin, the dose required to produce a therapeutic effect can vary from 0.5 milligram a day to 20 milligram a day, which is a 40-fold variation. And so we've been trying to work out what are the factors that determine that 40-fold variation. And in a white Caucasian population, we've been able to show that there are two clinical factors. One is age, so that as you get older, you need lower doses of warfarin. One is body mass index, that as you get heavier, you need more warfarin, and those are all logical. And the other two are genetic factors. When we put it all together in an equation, we find that the genetic factors account for more of that individual dose variation compared to the clinical factors. But when you put it all together, all those factors together, you can account for about 60% of the dose variation in warfarin per day based on that. Now, that is, you may say 60% is not very high, but actually 60% is much better than about 5% that we had before.
Yeah, absolutely. At the beginning of this episode, I described the scenario sometime in the future where we will carry our genetic information on a card or have it on file in a doctor's office. How realistic is that?
So that is already happening at the moment in the United States in certain sort of universities and hospitals. So Vanderbilt is one example. Mayo is another example. In Florida, they're also doing this. Is that they've genotyped individuals for certain particular genes and certain variations in those genes, polymorphisms, and they're putting them in the electronic record so that when the patient comes up to their doctor, this is flagged up that the patient has a particular variation in that gene. And then there is a decision support system which says it might be better for you to try an alternative drug, or it might be better for you to be able to reduce the dose in that particular individual with that particular variant. So that is already going on. The issue with that, again, is that the evidence that this truly works is small scale at the moment. And so the people in the United States are trying to collect much larger scale data, evidence to show that it's beneficial. But also in the EU has funded a big program of work, and Liverpool is one of the sites for that. And we're undertaking a randomized comparison of when you have this kind of preemptive genotyping available to the doctor compared to standard care, to see whether preemptive genotyping reduces the possibility of these adverse effects from giving drugs, commonly used drugs, to particularly our elderly patient group, which is very important. So that's what's happening at the moment. Obviously, as we move forward and as sequencing becomes much more commonplace, it is likely that there'll be more and more of the population will have their whole human genome sequenced, and that data will be available at source to the general practitioners or hospital doctor, and then one will be able to know what particular variants you have in your genome, and how you need to be able to handle the drugs.
It sounds so promising on the one hand, but on the other, it can sound somewhat terrifying to anyone who's concerned about their privacy. Because it's difficult to imagine information that is more private than one's entire genetic code. And an example of where this can be a real issue is with private insurance companies that might use this information as a reason to not cover people.
Obviously, people have concerns about the genetic data and privacy of genetic data, and those are concerns that need to be discussed and debated in terms of where and who the genetic data is available to. Clearly, we already give quite a lot of confidential information to our doctors anyway. At the moment, it's stored in a confidential place in your medical record. And I guess if you have genetic data in your medical record, it will be handled in the same confidential manner. It is also important to note that all of us have at least 70 deleterious mutations in our body. And so there's no perfect human being. So that's important to note as well. But when you actually look at the kind of pharmacogenomics area, what we're looking at common variations. Every one of us has that common variations, and in a way, not knowing is far more adverse in terms of insurance than knowing, because if you know, then you can actually define what doses you can give and what adverse drug reactions you can avoid. So that may actually be beneficial in insurance terms to have that knowledge than not to have that knowledge. The other thing also is that obviously insurance companies by law, at least in EU and United States, are limited in how they can use genetic data to be able to weight insurance premiums as well at the moment.
How quickly is this field advancing?
It's advancing very quickly. Obviously, the sequencing technologies are becoming more and more efficient, and the cost of sequencing is also going down. And the ability to analyze a genome is also improving rapidly. I guess the biggest issue that we face is that the human body is complex. It doesn't just rely on genetics. There are many other things which are going on. All of us are different. We eat different things. We do different amounts of exercise. Some people smoke, some people drink heavily. And all of that affects the way your drugs work, how you respond to disease. And capturing that will be very important as well. And we are getting better at capturing that, for example, through the many wearables, Fitbits and so on that people wear, Apple iPhone, etc. And all of those will be important kind of technologies to capture the environmental aspects. So the big challenge for people working in this area is going to be capturing not only what goes on in a very complex bodily situation, but what also goes on in a very complex environmental situation, and integrating the two together so that you come up with the right kind of answers.
Yeah, I mean, it's genetics are a critical, important component, but in the machinery of your health and your body. But my God, it's a complex machine, and so it's just one component.
Absolutely. So it's not going to be easy. It's a challenge, but it's exciting as well in terms of how quickly it is progressing.
Very exciting stuff. Thank you so much for speaking with us about it.
No problem.
Professor Sir Munir Pir Mohammed is the NHS Chair of Pharmacogenetics at the University of Liverpool. And that's another episode of the University of Liverpool podcast. If you are interested in personalized medicine or public health, we have links in the notes for this episode, which you can click on. And if you haven't already, please rate and review the podcast in iTunes, or even better, share the podcast with your friends. We are now in the higher education charts in 30 countries around the world, which is very exciting. So thank you so much for all your support. We will have another episode up in 2 weeks. Thanks so much for listening. I'm Neil Morrison.
You're listening to the University of Liverpool podcast, brought to you by the University of Liverpool online programs. Make a plan to advance your career today. Study a postgraduate degree with a world-class university without leaving your home or full-time job. You don't have to go far to go further.